And today the topic of management. So in our day-to-day cases in our IP and ICUs, we see a lot of patients requiring IV fluids like normal saline, ringer lactate, 5% dextrose. So how do we, what kind of fluid we need to give, and what kind of patients, and also what is the amount of fluid we need to give them. So we are going to discuss based on the case-based scenarios. Before going to that, we'll have a brief introduction about fluids and what are the constituents. So this is actually the total body water. Total body water is about 0.6 into total body weight. Let's say 70 kg and 42 liters of water is there. In that, one third of the total body water, one third of the total body water is present in the extracellular fluid. Two third is present in the intracellular fluid. So in that one third, so interstitial fluid constitutes 75%, that is 10.5 liters. So extracellular, the plasma, whatever intravascular fluid we are talking about, is only one fourth of the extracellular, that is 3 liters. Out of the 42 liters which is present, only 3 liters is present in the extracellular fluid, that is in the intravascular volume. So that is very important. So we go into the next slides. Why is this graph important? We'll discuss in the next slides. So before giving any fluid, you need to understand what is the primary reason why you are giving fluid. Let's say patient is having diarrhea, let's say patient is having vomitings. So what is your primary target? Are you correcting the electrolyte imbalances? Are you correcting the blood pressure? Are you correcting the glucose concentration? That is very important. So based on that, you need to monitor those parameters. Let's say the patient is in shock, so you need to monitor the urine output, you need to monitor the lactate levels, so that if they're recovering, maybe the patient is improving in the fluid. Otherwise, you need to titrate the fluid rate whatever you are giving. And also, if the patient also, you need to monitor whether the patient is having overload features, like patient is going to pulmonary edema, or the patient hematocrit is decreasing, that is suggestive, one more suggestive of overload features. And also the patient is having RV function is deteriorating. How is the IVC compressibility? IVC compressibility is one more thing. If IVC is no more compressible, that means the patient is overload. There is a fluid overload in that patient. If the patient is IVC is more than 50% compressible, that patient is dehydrated. You can give more fluids also. So these are all the parameters you need to take into the consideration before up rating and down rating the patients, and how is the patient whatever target we are, like whatever the reason, is it being corrected or not. So these are the various common types of fluids we give. Mostly we prefer crystalloids only. In almost all the cases, in any shock or any cardiogenic causes, any RDS patients, even trauma patients, all of those patients, we prefer crystalloid fluids only. The most common fluids we use are dextrose, sodium chloride, ringer lactate, and plasmolite A. The most common is dextrose and sodium, NaCl and ringer lactate. Colloids, we know albumin, starch, and blood products. All products are colloids. So in them also, in crystalloids also, there are hypotonic solution, there are hypertonic solution, and there are isotonic solution. Hypotonic solutions are those which have osmolarity less than our serum osmolarity. Isotonic are similar to our serum osmolarity. Any hypotonic is anything osmolarity more than our serum osmolarity. So these are the various constituents of the our normal day-to-day solutions we use. So the normal saline has a osmolarity of 308, almost similar to our serum osmolarity. It has 154 of milliequivalents of sodium, 154 milliequivalents of chloride. Whereas D5 and 5% dextrose, this dextrose in normal saline, D5 in water. This normal saline, dextrose in normal saline has 154 milliequivalents of sodium and 144 milliequivalents of chloride. So here 50 grams of per liter of glucose is also being added. That constitutes the osmolarity. But the thing is, whenever giving the DNS, let's say you give the DNS to the patient, so but this dextrose, whatever we're giving, it is rapidly metabolized by our body, so it doesn't account for the osmolarity we are giving. Though it is present in the outside, when we're giving the fluid, it constitutes the osmolarity. When we are giving it, actually dextrose doesn't account for any osmolarity because it is rapidly metabolized by our body. Only sodium chloride which constitutes the osmolarity. So next thing, the 5% dextrose which doesn't have any sodium chloride, which has only glucose. So this actually acts as isotonic solution, like purely it has isotonic, and it doesn't have any. In fact, it is a hypotonic solution because this 5% dextrose is 50 grams is rapidly metabolized by the body. So 3% LAC is hypertonic solution. It's 513 milliequivalents of sodium is present, and it has osmolarity of 1026. And ringer lactate is almost isoosmolar. It has 130 milli. It's more balanced. 130 milliequivalents of sodium, 109 milliequivalents of chloride, and 4 milliequivalents of potassium, and 3 of calcium, and 28 of lactate. So when do we use, what is the primary concern? In most of our cases, we use for any resuscitation and all, we use normal saline. If the patient is having hypoglycemia, patient to maintain the sugars, if you want to correct the hypoglycemia, we use D5 or DNS. If the patient is having more of diarrhea or something, we use ringer lactate. So in the next slides, we will discuss about what kind of fluids we use in the per condition. So these are the indications for dextrose. One, any correction of total body water. Any patient is having, you want to correct the total body water. So this is when you account, you explain why the first slide is important. To replace the total deficits of total body water in the treatment of hypernatremia. Why it is telling total body water? Because whatever 5% dextrose you are giving, this is rapidly metabolized. So whatever fluid you are giving, let's say 500 ml of fluid, it is equally distributed between the intracellular fluid, extracellular fluid equally. So like what in this composition is like 75%, 66% go to the extracellular fluid, 33% goes to the 66% goes into the intracellular fluid, and 1/3 goes into the extracellular fluid. Let's say 500 ml you are giving, whatever 320 ml goes to the intracellular fluid, 180 ml goes to the extracellular fluid. But if you are giving NaCl, most of it is stored in the extracellular. It doesn't go to the intracellular fluid, because NaCl, it is what this is, the osmolarity has 308. These are sodium and chloride. So this helps in retention of this 154 of sodium and chloride have osmolarity that help in the putting like preserving the water in the extracellular space. So whatever normal saline you are giving, it is mostly going to the extracellular space. But if you are giving 5% dextrose, which doesn't have any osmoles, which to maintain to keep the water in the extracellular space, so it is distributed 2/3, 1/3 in the intracellular space and extracellular space. So that is what the important point in the what is the role of 5% dextrose, what is the points of normal saline, what is the 0.45% NaCl. 0.45% NaCl or D5 account like half, like in the 0.45%, like half act as NaCl. Let's say 500 ml is giving, T50 ml is distributed completely in the extracellular space. Other 250 ml acts as the free water, like in the 5% it acts as free water. It distributes 2/3 in the intracellular space and 1/3 in the extracellular space. So if you're giving 500 ml, around 250 plus around 120 or something goes into like 250 of 130 is around 70. Around 320 ml goes to the extracellular space. Other 180 ml goes into the intracellular space. So that is the more important thing you need to remember. That is why it is important. That's why to replace the total body water, because once 5% dextrose is infused in the body, dextrose is metabolized. So to access the free water, so it is distributed 2/3 in the intracellular space and 1/3 in the extracellular space. So it accounts for the total body water. So it is mostly used in the case of hypernatremia patient. That is important to provide any energy and the prevention and the starvation ketoacidosis, any hypoglycemia or aminoacid. So do not give 5% dextrose in the SIDs, because it provokes the hyponatremia, because it is mostly hypotonic. So it provokes hyponatremia, it causes more dilution, so that it may cause a dangerously low sodium. And also, so do not give 5% to expand extracellular fluid alone. So because D5 doesn't have any osmol to hold the fluid in the extracellular space, so that is why you should not give it alone to expand extracellular fluid, especially if you want to expand extracellular. So use sodium chloride NS solution or ringer lactate solution, because they have sodium and chloride which are osmoles to continue. So most of the fluid you are giving is holded in the extracellular space. So NaCl to expand extracellular fluid in the hypovolemic state, and to treat the hyponatremia patients, or to treat the sometimes metabolic alkalosis related to the dehydration also elimination. So in that cases you can use, or to treat the hyponatremia patient, especially in the case of any vomitings or something, who are having hyponatremia and hypokalemia. So in that patients you can use, and it's mostly for any contrast study you are giving for hydration purpose, you use in critically ill patient, all shock, ARDS, all those patients. Mostly for resuscitation you prefer normal saline only. But always use it in the caution in the case of any liver failure or heart failure patient, because sodium overload is a problem in them, because it has 154 milliequivalents of sodium. So in them the problem, so sodium overload patient, always in the case of heart failure or liver failure, always use it cautiously, because there is sodium overload is a problem, because hypernatremia is one of the prognostic factor especially in the cirrhotic patients. So ringer lactate, it is also isotonic solution, but it is a more balanced solution. It has more sodium, chloride, potassium, calcium, lactate, all are balanced. So this is a more balanced, especially when there is a electrolyte losses more, especially in the case of burns or trauma or any like there is like in diarrhea where the significant electrolyte loss is there in them, especially potassium lost, especially potassium chloride, all are lost in them. You can prefer a ringer lactate solution. Do not use the patient generally we do not use this patient in the case of ECF alone, because unless the patient has hypokalemia and hypobarbituremia, you do not use this as a volume expansion solution, because if there is hypokalemia, hypobarbituremia, you can definitely use it. But because whatever lactate we are giving is converted to bicarbonate, so it can correct the bicarbonate. So like little bit of 4 milliequivalents of potassium is also present. So hypokalemia can be, but you don't routinely use it as a volume expander in the case of shock and all. So in the lactic acid dose also you do not use, because whatever ringer lactate, the lactate does as lactate, it can worsen it actually, but it per se doesn't worsen metabolic activities. But whatever lactic acid you do not use, because ringer lactate itself has lactates in it. And also in renal failure also you should use it in caution, because the risk of hyperkalemia in this, because let's say renal failure itself can cause hyperkalemia. It has our ringer lactate solution has 4 milliequivalents, but there is always a debate whether we should use the ringer lactate solution in hyperkalemia patient. Generally we can use it, because per se it has 4 milliequivalents of ringer lactate has hardly 4 milliequivalents of potassium. Our body is itself is like 3.5 to 4 points. Generally it doesn't have significant potassium, high levels of potassium in ringer lactate. So we can use ringer lactate in hyperkalemia patient. It doesn't cause hyperkalemia per se, but it should use it cautiously, because there is a risk of hyperkalemia, because it has some amount of potassium, but that doesn't cause hyperkalemia. But if you ask me if you can use ringer lactate in hyperkalemia patient, I think you can use it, but because it doesn't have significantly high levels of potassium in it, it has 4 milligrams, almost same as our serum potassium concentration. And use cautiously in hepatic, always in renal failure and hepatic failure patient, always use the ringer lactate in caution, because whatever lactates you are giving, they need to be metabolized by liver. So if there is hepatic failure, there is a risk of lactic acidosis also. And renal failure, there is a risk of there is a risk of acidosis, one more, there is a risk of hyperkalemia. So if they are not there, you might try monitoring the parameters. So albumin mainly in the case of if you expand the plasma volume, if the crystalloids are not working. So in any nephrotic syndrome patient or a liver failure patient where there is a low albumin levels, especially after paracentesis, after 5 liters we give albumin. Just before 5 liters of paracentesis, like abdominal, we do the ascitic fluid tap. Now before 5 liters we do not require any albumin infusion, but after 5 liters, like more than 5 liters, if you are paracentising, you can give albumin. And also in the case of hepatorenal syndrome you can give. So these are the various reasons. So you do not routinely use in the malnutrition patient like albumin. You do not, like all the patients are malnutrition, don't routinely go and give albumin infusion to everyone unless there is a protein losing enteropathy where significantly low albumin is there. So what is the cutoff where you give albumin infusion, where you give protein powder? Yeah, read about it and let me know what is the cutoff where you give albumin infusion. And generally in the routinely critical ill patients also, you don't routinely give albumin in all of those patients. First you try crystalloid. So then if still not improving, then you might try colloid. So but preferred solution, all the trauma, critical ill patient, all surgical patients, is mostly crystalloids only. So this is the distribution. Let's say you give 250 ml of fluid. So I told you D5 water actually acts as a free water. So it is 2/3 is distributed in the intracellular fluid, 1/3 is distributed in the extracellular fluid. But normal saline ringer lactate is distributed mostly in the extracellular fluid. That is 75%, 25%. That is intravascular 62 ml and extracellular space, that is 188 ml. So most of the normal cellular ringer lactate, whatever we are giving, is distributed in the extracellular space. So this is important thing. So if you are giving 5D, it is constitute more. It is distributed in the entire body. So that is the most important thing you need to remember. So this is one more thing. If you are getting packed RBC, most of it is going into the intravascular space. This is the most important equation you need to remember. See, if you are getting packed RBC, you are directly giving 250 ml of fluid directly into the intravascular space. If you are giving ringer lactate 250 ml, you are giving 62 ml into the intravascular space, 180 ml into the interstitial space. So this is important. I hope you understood the concept. I'll repeat it again. In normal saline, they have osmoles like sodium and chloride that can help in holding the water in the extracellular space. That is why most of the water is distributed, whatever fluid we are giving is retained in the extracellular, that is distributed in the interstitial and intravascular space. But in D5, it doesn't have any osmosis. Whatever dextrose you need is rapidly metabolized. So it is distributed in the entire body in the same proportion. Like 2/3 goes into the intracellular, 1/3 goes into the extracellular space. So this is the how. So what is the amount of fluid we have to give in a patient? So what is the, let's say if a patient is giving, he's put a nilparol, what is the maintenance fluid for that patient? There is various formulas, but this is a simple formula you can remember. Let's say a patient is having 70 kgs or something. So they should always count for insensible losses, like that your sweat, the respiratory secretions, whatever you are going. So these are various insensible loss, that heat related loss is there, some amount of water is lost and heat related. So these are all need to be around 8 to 12 ml per kg per day is the insensible losses. But it increases for every 1 degree, for about 10% increase should be given for every 1 degree rise in temperature. So let's say 80 to 12 ml per kg is the baseline. It comes around 560 to 840 ml for a 70 kg person. So then you account it for the, let's say, urine output also. Let's say urine output is around 500 to 2000, whatever urine output is there, and this and you added these both together. Let's say urine output is 500 to 2000 ml, and insensible loss is around 8 to 12 ml per kg, is around 560 to 840 ml. You add them both, it comes around 1000 to 2500 ml based on the urine output. So these are the maintenance fluid. This is how you give it around 30 ml per kg per day, is what is the amount of the maintenance fluid you give actually. So this is the fluid requirement. So this is the maintenance fluid you give in the body, so that accounts for the both urine output and insensible losses. So based on the shock and all pre-renal AKI, you can add on further fluid, and you can add on like like let's say pre-renal AKI is there, you add plus 500 or plus 500 to 1000 ml, and add extra solid so to recover the patient from the pre-renal AKI. Let the patient is in septic shock, you initially give 1 liter bolus of normal saline, then you put them on the main, and then you put them 100 to 150 ml per kg per hour or something, so until the patient BP recovers. Once the patient BP recovers and normal is there, then you can go for the maintenance fluids. That is the this is the requirement. You account for the insensible loss around 8 to 12 ml per kg per day, and add the urine output around. So this is the basic requirement, and you can add based on the pre-renal AKI is there, around 500 to 1000 ml is added. If the septic shock is there, if the patient is shock is there, that is a different game where you need to give more amount of fluids. But basic requirement is this. So then there is one more thing. So if you are giving, like, let's say let's say a patient is coming into DK, you are giving you give a lot of amount of normal saline, you give around 10 liters of normal saline. You observe the patient is still in acidosis. You do not understand. The patient is in bicarb is still 16. The patient is having mild acidosis. And if you are checking at the electrolyte, sodium is around 148 and chloride is around 120, 116 and 118. So what is the cause of acidosis? So there is a study in the recent literature whether we should use ringer lactate as a more resuscitating fluid than normal saline. Like unless there is a contraindication like any renal failure or hyperkalemia, like we can use in them also. The like have liver failure, the contraindications are not there. So why we are preferring ringer lactate or normal saline in these studies is because whatever normal saline we are giving, it has high amount of sodium and chloride. So whatever high this chloride is there, that chloride is supraphysiological. That is more than what our normal serum was. Like normal serum has around 100 to like 90 to 110 around chloride is there. But whatever sodium chloride we are giving, it has 154 milliequivalents of chloride. So they are risk at hyperchloremic metabolic acidosis. Why hyperchloremic metabolic acidosis is occurring in this patient of normal saline, high amounts of normal saline infusion is because, so when you give high amount of chloride to the body, so it decreases the anion gap. Before I discuss in the metabolic acidosis what is the anion gap and all. So if you give more amount of chloride, it causes elimination of bicarbonate from the kidney. So that causes metabolic acidosis. So more amount of chloride we give, it causes elimination of bicarbonate. To maintain the anion gap, it causes elimination of bicarbonate in the body. So it causes metabolic acidosis. One more thing is, if there is hyperchloremia in the body, it causes vasoconstriction. It prevents the release of icosanoids and prostaglandins. So it causes vasoconstriction, especially at the glomerulus level. So it can predispose the patient to the AKI also. So these are the major risk factors with the like the normal saline, high, like large amounts of normal saline infusion. There is a risk of hyperchloremic metabolic acidosis, and there is a risk of AKI also. That is why, especially when the patient is not having any contraindication like any renal disease is not there, hepatic disease is not there, the patient is not in shock, you can, for maintenance, you can prefer ringer lactate as a better solution because it has more balanced amount of sodium, chloride and potassium is there. But for resuscitation and all, for initial resuscitation, especially in any shock or anything, you can initially give normal saline as a solution. For other maintenance, you can try ringer lactate. So this is the case base. I hope you understood. A 24-year-old man is admitted for fevers and chills and weakness. She is found to have hypotension and tachycardia. Blood cultures are also positive for Staphylococcus aureus, and the diagnosis of septic shock is made. There is no peripheral edema. Based upon the sensitivity, the patient is found to be started on vancomycin. The patient labs are sodium are 144, glucose is 80 milligrams per deciliter, and potassium is 5.1, and total protein is 5.8, and also chloride is 88, and also albumin is 2, and bicarbonate is 20, hemoglobin is 10. So blood urea nitrogen is 30 and hematocrit is 30%, creatinine is 1.7. So what is the case? The patient is having, firstly the patient is in septic shock. Base sepsis, there is septic shock. Sodium is 144 and glucose is 80. So sodium and potassium, potassium is on higher side, there is AKI also. So first we said in the case of renal failure and hepatic failure, we generally avoid ringer lactate because there is a risk of hyperkalemia and also there is a risk of lactic acidosis and all. So we avoid that ringer lactate is there. And since the septic shock is the preferred solution is always normal saline in this case. After normal saline, after hemodynamic, let the patient is corrected with hemodynamic stability, the patient shock record, because there is a high sodium, maybe we can go for 0.45% and less later. First initial choice of fluid is always a normal saline in this patient until the BP recovers. Once hemodynamical stability is HU, then we worry about the hypertonicity related to the sodium 144. So then you go for 0.45% and NSR like 5D based on the tonicity and based on the glucose concentration. You can monitor it later. But the present day, at the present day electrolyte parameters, you go for normal solution of choice. So what is the appropriate initially? Always normal solution. Normal solution is an appropriate fluid of choices. But once the BP is corrected, since the sodium is high, you can convert it to 0.45% or 5% extras based on the glucose concentration. If the patient is going to hypoglycemia, you can go for 5% extras also. So at what stage does the patient require any blood transfusion? Since the blood to raise HB greater than 10. So what is the target for blood transfusion in any patient with critical illness? So let's say a patient is having upper GI bleed or anything. So any HB less than 7 is an indication for transfusion. Any patient less than 7, hemoglobin less than 7 is indication for transfusion. So anything more than 7 you can manage with fluid unless the patient has heart failure or something. So if the patient is having heart failure or have a decreased oxygen supply is there or impaired oxygen delivery is there. So in that cases you might give transfusion unless they are not, there is no heart failure, there is no impaired oxygen delivery or anything. So there is no nothing, other indications are not there. Mainly the indication is only heart failure to maintain the HB more than 10. So in all other conditions, HB less than 7 is the only indication for transfusion. So more than 7 you can manage it conservatively with fluids and all. So only heart failure or any impaired oxygen delivery is there. Only then you can go for transfusion if it is less than 10. Then the target are more than 10. So that is the indication. In this patient, there is no heart failure, impaired oxygen delivery is not there. You initially manage, then the HB is 10 here. So there is no point of increasing it further. So there is no heart failure or any impaired oxygen delivery. So you maintain the, manage with mostly with fluids. So transfusion in this patient is required only when the HB is less than 7. At what stage does the patient need infusion of 5% albumin? Let's say this is a colloid. So let's say the patient is having still not recovering with the fluids or any. So then if the patient is not recovering fluid, you go for inotropes. If the patient is still not recovering, then you might try colloids, but we don't routinely use colloids in our day-to-day practice. So then you initially go for inotropes. Then if possible, if still not recovering, if there is no albumin or something, you can try colloids. A 30-year-old man is admitted to the traumatic service with multiple abdominal wounds that raises splenectomy and repair of several organs. He has multiple surgical drainages. His blood pressure is 120 or 80 and pulse rate is 80 per minute. His labs are sodium are 134, potassium is 3.1, calcium is 7.8, glucose is 80, chloride is 88, phosphate is 3.5, bicarbonate is 21, blood urine nitrogen is 31, creatinine is 1.1, urine potassium is 10. So in this the patient is normotensive but having surgical severe drainages. These drainages are, so any diarrheas, any drainages, any traumas, any burns, in this there is significant electrolyte loss. So all these cases the preferred always ringer lactate is a preferred solution because in them the patient doesn't have any AK, the BP is all normal, you are not increasing extracellular. Here main role is the depletion of electrolytes. So in this the main solution of choice is always ringer lactate to correct the electrolyte imbalance with low potassium, the chloride also, and there is low calcium is also a little on the lower side. So there is a multiple drainage, there is a loss. In this the ringer lactate is a solution of choice. So in the ringer lactate, so when would you give 5% dextrose or normal saline? So generally we can give 5% extras or normal saline. Just I will prefer normal saline if the patient is in shock or something. So and also 5% dextrose we only give to replenish if the patient is having hypoglycemia or the patient is having hypertonicity or something. But here that is not the case. But generally in this case the patient BP is normal. I will go for ringer lactate only. 1 week later the serum creatinine is blood urine nitrogen is 2.1 and 40 and the respectively the potassium is acute kidney injury. The patient is found to have AK and his serum potassium is 4.8 and is euvolemic. So here in this case the patient is euvolemic, then you might not go on ahead and give ringer lactate because patient is having AK and all the patient is having little bit of upper side of potassium. So you avoid in these cases you might try normal saline or 5% dextrose. So in this condition you can try normal saline or 5% dextrose based on the glucose. Whether the you need fluid volume expansion or you need to maintain the glucose, based on that call you can take. Let's say if you need the more of extra volume expansion, you go for normal saline. You want to maintain the total body water and glucose, you go for 5% dextrose. In this, if this is the criteria, you go for these cases. What would happen if ringer lactate? There is a risk of hyperkalemia. A 70-year-old man is admitted to for the electrolyte surgery or the elective surgery of the prostate gland. His weight is 70 kg. His serum electrolytes and glucose are normal. He's put on nil per oral. So what do you advise in this patient? What is the fluid and electrolytes order in this patient? So how much you require in this patient? So let's say urine output is 1400 ml. Urine output is 1. What is insoluble hydrochloride? We already told 8 to 12 ml per kg per hour. That comes around 600 ml. So we already discussed in this slide. So the sodium, I forgot to mention, the requirement of sodium is around 1 to 2 milliequivalents per kg per day, and potassium is generally half of it. So let's say 1 to 2 milliequivalents, around 70 to 140 milliequivalents is the requirement of sodium. So this since urine output is 1400 ml, insensible loss is 600 ml at around 8 to 12 ml per kg per day, and sodium requirement is 1 to 2 milliequivalents per kg, that is 70 kg. We require 1 milliequivalents per kg, that is 70. You can take 2 also if the patient is having hyponatremia. Since the patient is having normonatremia, we are taking minimal only. Since the patient is having normal potassium also, we are taking minimal. Generally 40 to 80 is the requirement. We took around 40 because potassium is all normal. So this is the formula you need to keep all the patients on nil per oral. What is the urine output? What is the insensible losses? What is the sodium requirement? What is the potassium requirement? If the patient is having hyponatremia, this requirement will increase. If the patient is having hypokalemia, this requirement will increase. And what is the glucose requirement also? So we put all those patients, many patients on dextrose normal DNS solution and 5Ds. So what is the carbohydrate requirement? Generally, what is the minimal carbohydrate? Carbohydrate is not the essential nutrient of the body, because but body can generate glucose from protein and gluconeogenesis pathway, glycogenolysis pathway. There are many pathways carbohydrates, glucose can be generated in the body. So carbohydrate is not the essential nutrient of the body. But we need to give a certain amount of glucose to the body to prevent the starvation ketoacidosis. That is around 50 grams. 50 grams is the amount of glucose needed per day to prevent the starvation ketoacidosis. So 50 grams is the requirement, but we need to give, there is a minimal carbohydrate requirement to maintain the brain glycolysis and all. That is around 2 gram per kg per day. For this patient it will come around 140 grams or something. That is a minimal carbohydrate requirement. But per se any critical ill patient, that is there is no essentiality of putting 4% like not have amount of carbohydrate requiring. The patient is requiring eating that dextrose is also not, because patient eats, then carbohydrate will be taken care by the meals and all. You need not put them on DNS. But if you have to give for nil per oral patient, around 2 grams per kg per day is the requirement. That is around current 140 grams or something for 70 kg one. But to prevent starvation ketosis, around 50 grams. But minimal carbohydrate requirement is 2 grams per kg per day. And you maintain the sugars around 140 to 180 milligrams per deciliter in a day. So that is the that is the target levels in the body. So in that, based on that, you can titrate around 3 grams per kg per day or 4 grams per kg per day. Based on the glucose levels, you can titrate it upwards. But minimal is around 2 grams per kg per day. So don't give over DNS also, because high sugars are also very dangerous. That is the main one. So you always put this formula in this case: what is the urine output, what is the insensible loss, what is the sodium requirement, what is the potassium requirement, what is the glucose requirement. So that is the formula. So thus in this patient you require around 2 liters, that is around 1400 ml plus 600 ml, you require 2 liters. So in that you are giving one as half normal surrender at 83 ml per hour for 12 hours, and other you are giving dextrose 5 water with KCl 40 milliequivalents around 83 ml per for 12 hours. So this will around 2 liters of water they will give. They will give 77 milliequivalents of sodium, whichever you reckon, that is a half normal saline will have that. So that will take care of that 77 milliequivalents, and 40 milliequivalents potassium we are giving here, and dextrose will have 50 grams of glucose also. So that will prevent the starvation ketoacidosis. So this constitutes the whatever fluids we are giving, that is by like IV salines or in medicines, all this combined 2 liters. So in medicines also we put the antibiotics in the 100 ml NS, or that will also count in this. So you need to keep them in. So the total fluid should include fluid that is required for medications also. If the patient is taking by mouth, that requirement will significantly come down. If the patient is taking by mouth, you don't require IV fluids at all, first place. Unless the patient is having diarrhea or vomitings, you don't require IV fluids. If the patient is taking by mouth, you don't require these fluids also, IV fluids also. So that is it. Thank you.